Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by SCB Bangladesh chapter and supported by Bangladesh Society of Medicine. Today, we have come to the 12th episode of our Acute Medicine series. On this episode, we're going to talk about a very important topic which a clinician doctor has to face almost every day during his clinical hours. Yes, we're going to talk about hypertensive emergencies. To talk about this important topic, we have one of the best and most talented, I would say, extraordinary clinician here with us. He is none other than Professor MD Mujibur Rahman. He is the Professor of Medicine, BSSMU, and Vice President of Bangladesh Society of Medicine. To chair this session, we have the legend of the legends, a true magician in the field of medicine, Professor Quazi Tarikul Islam sir. He is the founder governor of SCB Bangladesh chapter and former president of Bangladesh Society of Medicine. As a panelist, we have two most renowned professors of our country. Firstly, we have every student's favorite professor, Professor MD Zakir Hossain sir. He is the Professor of Medicine, TMSS Medical College and founder Chairperson of Hypertension and Research Center, Longpur. We have another renowned clinician here with us as well. My mentor, Professor MD Uddin sir. He is the head and Professor of Medicine, Popular Medical College and member Executive Committee, Bangladesh Society of Medicine. To moderate the session, we have young and talented Dr. Rahatun Nayeem Maglin with us. She is the Junior Consultant, Medicine, NINH. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Rahatun Nayeem Maglin. Dr. Rahatun Nayeem Maglin.
Good evening to all the viewers, respected teachers. Thank you, Dr. Prince Kawser, for I feel honored and privileged to Bangladesh for
Sir, I guess there is a technical difficulties with Jannatul Naeem Maglin Apu. Sir, I would request you, Mujibur Rahman sir, I would request you to start the presentation, sir. Please,
Okay.
sir. Would you please?
Thank you. I think Maglin is disconnected or might have some problem with net connection. And that is why I was just not hearing anything from her. Thank you, Dr. Maglin and also Prince. Respected chairperson and my dear panelist and the audience. Assalamu alaikum. It's my privilege to be here with you in this evening with a very important topic like hypertensive crisis, the emergency situations of hypertension, the acute rise of blood pressure in some situations. It's not very common, but we used to face these sorts of problem in our everyday clinical practice now and often. The scope of discussion of today's presentation is acute rise of blood pressure in situations other than pregnancy. Definitely, I will not mention the pregnancy, the eclampsia, and pre-eclampsia in my presentation, because that needs description, which needs other also important session. Some of the important definitions I will just describe, and I will try to present some of the evidences in relation to the treatment of this emergency situation, and how rapidly the treatment should be started, and how rapidly it should be reached to normal, and also in some situations few guideline recommendations from international guidelines, the latest guidelines. I don't have any conflict of interest. Before going to my presentation, I will describe two cases. The first case is a 58-year-old woman with known hypertension presents with headaches, blurring of vision for last 3 days. Her prescribed medications include amlodipine, hydrochlorothiazide, lisinopril, but she acknowledged that irregular medications that has not taken any of the drugs for last 3 days. On examination, she is anxious but comfortable. Patient has average of multiple seated blood pressure measurement is 236 by 124 millimeter of mercury, and the heart rate is 68 beats per minute. Fundoscopy shows arterial narrowing, bilateral flame hemorrhages, coronal spots, and papilledema. Her vision is only to finger counting with very difficulties. Auscultation reveals normal heart sounds. Remainder of the examination is also normal. The electrocardiogram shows left ventricular hypertrophy, which is indicative of prolonged hypertension. Other laboratory tests and chest radiography are normal. The CT of the head showed heterogeneous hypoattenuation of subcortical white matter in the posterior parieto-occipital regions bilaterally, but no hemorrhage or infarction. What is the initial diagnosis, and how would you further evaluate and treat this patient? These are the questions, dear audience. Please remember, I will just highlight some points after my discussion of the topic. Case 2. A 55-year-old man presented for regular medical checkup. He's very anxious and apprehending that he might have some cardiac problem because a very close friend of him died of heart attack. It will be heart attack very recently. On examination, his average seated blood pressure was 222 over 120 millimeter of mercury, pulse is 106 beats per minute, and other systemic examinations revealed nothing abnormality. His ECG showed tachycardia, X-ray with normal X-ray, and urinalysis is also normal. Other relevant lab tests are also normal. What is the diagnosis? How will you evaluate and treat? The questions are the same. So, come to the topic, the hypertensive urgencies and emergencies. This is a bit acute condition. The severe acute rise of blood pressure more than 180 millimeter of mercury and or diastolic blood pressure more than 110. In some descriptions, you will find 220 over 120. But the minimum level in different literature is more than 180 and more than 110 millimeter of mercury. These conditions, that is the acute rise of very high blood pressure, may be associated with a variety of acute life-threatening complications, and any one of which is considered a hypertensive emergency. You see, the brain, ischemic stroke, cerebral hemorrhage, the PRES, the posterior reversible encephalopathy syndrome, the retina, hemorrhage, exudates, and papilledema. In the heart, acute coronary syndromes, acute heart failure, large vessels like aortic dissection, kidneys, acute kidney injury, eclampsia, and preeclampsia in pregnancy. So whenever very high rise of blood pressure is associated, any one of these is known as hypertensive emergency. Whenever this emergency, the acute rise of blood pressure is not associated with these sorts of diseases, the target organ damage, then it is known as hypertensive urgencies. The difference between urgency and emergency is clear, is it? Whenever this situation is present, these conditions are present, it's a dire emergency. You need to reduce blood pressure within hours. It's reduction of blood pressure, not too normal, mind it. But whenever there is absence of these conditions, that is the hypertensive urgencies, you need not to reduce the blood pressure very aggressively, then hours to days will be requiring to reduce the blood pressure, will be sufficient to reduce the blood pressure. Some older definitions, the accelerated hypertension and malignant hypertension. These two definitions were used once upon a time when we are trainees or student of the undergraduate level. Then we used this term accelerated hypertension and malignant hypertension. The first case, as there is papilledema, so you can say that that is malignant hypertension by the then definition. And the other case, it might be accelerated hypertension. But in some of the, in all the latest and the recent descriptions, they have omitted these accelerated and malignant terms. Evaluation. Whenever this patient has come to you, like our case, as I have discussed previously in my starting slides, you have to measure the blood pressure very meticulously. It is the average of at least 2 to 3 measurements. So, and it must have to be very seated blood pressure measurement if the patient is able to be seated. And other the procedures of measuring blood pressure, these are all the same. Patient must be seated, the foot must be rest on the ground, the arm should be rested on a table or any armchair on the side of the chair, and something like this. And then you will measure at least 3, sometimes 2, and average of the readings will be taken as the measurement of blood pressure. And you have to find out the precipitating factors. At the same time, you have to determine the presence of acute target organ damage, which is a very difficult situation. What are the precipitating factors? Non-adherence to prescribed antihypertensive medications, dietary sodium indiscretion, drugs like cocaine, amphetamines, sympathomimetic, NSAIDs, and high-dose glucocorticoid. Some are illicit drugs among these, the amphetamine and cocaine. Anxiety or panic sometimes can precipitate. Acute stroke can also precipitate, and heart failure. These are the precipitating factors. So you have to see all these conditions during evaluating the patients. Now, determination of target organ damage. You see, the acute stroke is heart failure. Both these two are the precipitating factor. At the same time is the target organ disease. Patients without target organ disease are usually asymptomatic. They are usually asymptomatic. Symptoms of any headache, typical chest pain, dyspnea, dizziness, lightheadedness, epistaxis, these are sometimes the association of very high blood pressure and sometimes may be associated with target organ damage, may not be associated with target organ damage. So you have to look for the target organ damage very carefully. We know stroke determination, fundoscopic examination, and also urinalysis. Urine examination is mandatory during evaluating procedure. I'm not going into the details of the evaluation because, you know, in all sorts of evaluation, history, physical examination, and some of the relevant lab tests are very important. In history, we can take from the attendant or even from the patient that how long he is hypertensive, what are the medications he's being on, and what is the status of being taken these antihypertensive. I mean, the adherence to the regimen that has been prescribed. These are very important because non-adherence are sometimes very important, as in my first case. As you have. So these are the clinical features, and you have to rule out physically from the clinical features and also the physical examinations. Now comes to the treatment. Before treatment, going to the treatment, you have to know the autoregulation of blood flow in the organs. This autoregulation process is well described and well studied by cerebral or by brain blood flow. You see, the autoregulation of organ blood flow refers to physiological adaptations that allow organ perfusion to remain relatively constant in wide range of blood pressure variation. You see, this is the risk at the normotensive level, and this is the if one patient is becoming hypertensive and remain chronically hypertensive, then at this level his tissue perfusion is maintained. It's a very balance between these two conditions. If it is reaches the cutoff value, then there might have some cerebral edema. If one tries to normalize the blood pressure below this level, then sometimes it can cause the deleterious effect on the individual. So in chronic hypertension, this curve shifts to the right. The cerebral blood flow is maintained at similar level, but the autoregulatory curve is shifted to the right. You see, this shift allows the patient to tolerate higher blood pressure levels without cerebral edema. So the patient can tolerate a higher blood pressure level. And that is why you can reduce the blood pressure to very normal level, because then there will be hypoperfusion of the tissues. That is why in this severe elevation of blood pressure, you have to be very cautious, and you have to be very cautious in reducing the blood pressure from the initial level to the target level. So the treatment of severe hypertension for several months may improve autoregulation to modest extent. This is chronic hypertension. If you treat, so how quickly it will come to this normal level? It depends on the initial severity of the blood pressure. If it is very severe, then it takes several months to come to the normal level. If it is mild to moderate elevation, then it may take up to days, 7 days. Within 7 days, it will come to the normal level. So it depends on the severity of the initial rise of blood pressure and how long the patient is having that blood pressure level in his body. That these two conditions will depend how rapidly we should reduce this blood pressure level. In hypertensive urgency, the IV medications are not needed. So far, the evidences we can see, we don't need IV medications. The blood pressure should be reduced over a period of hours to days, not very aggressively, although slower reductions may be needed in older adults or in patients with very high risk of cardiovascular or cerebrovascular disease, and determining how rapidly to lower blood pressure level. So there are several factors that will determine the rapidity and the target level of blood pressure. Now I shall present some of the evidences on these issues. The rapid reduction of severe asymptomatic hypertension. This is, at that time, it was published in Archives of Internal Medicine. Now this is known as JAMA. JAMA means Journal of American Medical Association. The journal has changed its nomenclature. It was in '89. At that time, they studied tinta group of patients. In group 1, hourly doses of clonidine hydrochloride followed by maintenance therapy. Group 2, an initial dose of clonidine followed by hourly placebo without clonidine and maintenance therapy without prior loading. So in this treatment, they try to see that without prior loading, only the maintenance therapy. So all 3 groups are similar in reducing the blood pressure. But the side effects, the mortality is higher in this initial group where the loading doses are given. So this loading dose concept has been omitted from the severe asymptomatic hypertension, that is the hypertensive urgencies. This is the initial description of, this is the registry of hypertension, severe hypertension registry. They have shown the readmission. Any readmission was 37%. Any readmission for acute severe hypertension, any readmission, this is readmission due to hypertension, is 9%. You see, and these 2 are the mortality. In-hospital mortality and after discharge within 90 days mortality. So in this study, they have shown that in the registry, quite a good number of patients readmit, quite a good number of mortalities are there. So how to prevent this mortality? Because in this group, they use these intravenous drugs. So after that, they have come to a decision that in severe acute rise of blood pressure, the intravenous drugs should not be used. This is a meta-analysis that showing which drug is better in urgency, the calcium channel blocker or ACEI. If you see the side effects, the calcium, this is ACE better. Regarding the flushing, that is due to vasodilators, the flushing is more with the calcium channel blocker. It is less with ACE inhibitor, so it is better. If we see headache is more with calcium channel blocker and favors the ACEI. If we see the requirement of additional drugs, so both the groups are equal, because in both the groups, the control require additional drugs on calcium channel blocker and or ACEI. So both the drugs can be started, and in both the groups, addition of another drug is needed. So these are the initial studies. This is important study published in 2009. So in the earlier description in late 80s, the sublingual nifedipine capsule, the liquid was provided under the tongue, and that was quite a recent time in Bangladesh. Some of our physicians also are using nifedipine capsules, liquid nifedipine sublingually. But this article, should a moratorium be placed on sublingual nifedipine capsules given for hypertensive emergencies and pseudo emergencies? You see, the review of the literature revealed reports of serious adverse events such as cerebrovascular ischemia, stroke, numerous instances of severe hypotension, acute myocardial infarction, conduction disturbances, fetal distress, and death. So these are the adverse outcomes of sublingual nifedipine that were given at that time. Given the seriousness of the reported adverse events and the lack of any clinical documentation attesting to a benefit, the use of nifedipine for hypertensive emergencies and pseudo-emergencies should be abandoned. This was the JAMA recommendation at that time, and following that recommendation, the FDA and other regulatory bodies has stopped the use of these nifedipine, and also the use of slow release or the rapid formulation of nifedipine has been abandoned, has been obsolete by the regulatory authorities because of these side effects. But the sustained release preparations can be used orally in some situations. Oral labetalol versus clonidine, which one is better? You see, both are equal in systolic and in diastolic blood pressure reduction. So clinical experience and descriptions of acute effects of clonidine and labetalol suggest that they may be associated with less abrupt BP changes than other agents. So these two agents are a bit better than other agents. The effects are equal after 6 months. If you see, after 6 months, it's equal. When to discharge these hypertensive urgency, we will start oral medication, preferably calcium channel blocker or ACI with another drug, and in some cases, combination of both of these in latest guideline. Then we will be following the guideline. Patients are generally discharged once symptoms have improved. Maniki, which often coincides with a decrease in blood pressure to a level below 160 to 100 to 110. Then patient can be discharged with frequent follow-up visits, like the first visit will be after 7 days, then another visit after 15 days. So frequent visits will be needed if you discharge very early. Now, the hypertensive emergencies. All patients should be admitted to ICU, preferably to ICU. If ICU settings, this is the Western literature, Western description, it must be, but in our situation, we cannot provide, especially in public setting, we cannot provide ICU in all the patients, but we have to arrange that, and we have to moderate the ICU, or in some situations, HDU settings, treated with intravenous antihypertensive drugs. We must use intravenous drugs. These are the usual intravenous drugs: the labetalol, nitroglycerin, nicardipine, hydralazine, nitroprusside. So the labetalol, nitroglycerin, these are available. Nicardipine, I don't think this is available. Hydralazine is available. Nitroprusside, I don't know. Hydralazine has got some unpredictable effect, leads to excessive blood pressure lowering, and should generally be avoided as a first option. So some evidences shows that this is the systolic blood pressure reduction, and these bars shows the number of doses requiring to reduce the blood pressure up to this level. You see in some patients more than 10, around 10, and you see about 50 doses of hydralazine has been given, but the blood pressure is 180. So it's very unpredictable. In some patients, it's precipitous fall of blood pressure occurs, and in some patients, blood pressure is unresponsive to hydralazine. That is why hydralazine is not advocating as a primary choice of intravenous therapy. So the other options are there. If we see the Cochrane systematic review, the pharmacological intervention shows that they have been postulated that there is insufficient RCT evidence to determine which drug or which drug class is most effective in reducing mortality and morbidity. So which class is most effective? In addition, which class or which drug is more effective in reducing morbidity and mortality? So there are insufficient literature. There are some minor differences in degree of blood pressure lowering between the drug classes. This review demonstrates a blood pressure lowering efficacy for nitrates, AC inhibitor, diuretics, adrenergic antagonists, calcium channel blocker, dopamine agonists. So these are the drugs they have proposed that those can be used in some situations of hypertensive emergencies. This is one of the important randomized comparative effectiveness trial of IV nicardipine versus labetalol. You see, this is nicardipine. The black one is nicardipine, and the red one is labetalol. You see, the reduction is more sustained with nicardipine, and the difference is clearly significant in these areas. And also, patients receiving nicardipine are more likely to have their BP controlled about 2.7 times better than the labetalol. So nicardipine is being proved that it is better than labetalol. But if nicardipine is not available, in that situation, labetalol can also be used like our situation. Goals of BP reduction, again, is very important, this goal. And the autoregulatory mechanism, you have to keep in mind this dynamic autoregulation mechanism. In the absence of studies comparing different rates of blood pressure reduction, management is guided by autoregulatory principles. The guidelines recommend that BP should not be decreased by more than 20 to 25% during first hour. So in hypertensive emergencies, we are allowed, or it is being recommended by the guidelines, that only 20 to 25% reduction in first hour. So you have to be very cautious, because if you reduce the blood pressure below this level, then this autoregulatory mechanism will fail and tissue hypoperfusion will be there, or lead to once it is reduced within first hour, then gradually it has to be gone to 160 by 100 during ensuing 2 to 6 hours. But it has to be, the patients are monitored very accurately and very cautiously. It may differ from the organ involvement to organ involvement, because in hypertensive heart failure, it will be different. In intracranial hemorrhage and the ischemic stroke, the protocol will be different, but it is a general guideline. If excessive BP reduction occurs, then discontinuation of IV drugs immediately, and in some cases, temporary use of vasopressor, intravenous fluids sometimes may be needed. Regarding this precipitous fall of blood pressure, I have one experience. During my internship training in 1985, at that time, in one literature, we found that Professor Azizul Kahar sir provided us a literature that sublingual nifedipine can reduce blood pressure dramatically. Then we start in some of the cases. You see, it was in 1985. So we are few under his supervision. He was at that time assistant registrar. We just were interns. In the night time, we, 2 or 3 friends, one patient came with severe rise of blood pressure, and we put sublingual nifedipine under the tongue. It was extremely high, and gradually the BP was going down, down, and down. And by that morning, the patient expired. And that was a dangerous experience for us. The precipitous fall, and you have to be very equipped with the situation, and you have to be equipped with the treatment armamentarium of those situations. So resumption of once the blood pressure is controlled, then resumption or initiation of long-acting antihypertensive drugs should be with IV drug. In some situation, but it differs. There is no hard and fast rule. In some patient, you can start alongside with IV drug, start the oral medication. It will give a profile. It will give a smoother transition from IV to oral route, shorten the need for IV drug and ICU care, and minimize the risk for rebound hypertension. Because IV medication, if you withdraw the IV medication, then there is a phenomena called rebound hypertension. Suddenly there is excessive elevation of blood pressure, and that is also being responsible for some of the organ damage at that situation. So sometimes this resumption or initiation of oral drugs can be alongside with IV drugs, but not in always. When to start oral medications? I have discussed one settings. The appropriate timing of starting or restarting oral drugs is uncertain. The risk of hypotension is greatest in the first 6 hours of IV therapy. Reasonable approach is to start oral agents within 6 to 12 hours after starting IV therapy. Long-acting drugs are chosen on the basis of standard guidelines for chronic hypertension management. After initial stabilization, experience indicates that most patients can tolerate normalization of blood pressure within 48 to 72 hours. But in some situation, you have to keep in your mind that the autoregulatory process or autoregulatory mechanism. So in every aspect of reducing blood pressure, you have to keep in mind that whether new onset of any organ damage is occurring, like the newer development of stroke-like features or convulsion or some sorts of visual disturbances. Some require long periods owing to dizziness, fatigue, and mental slowness. So this process differ individual to individual. It can be 72 hours. It can be longer periods of time, maybe seven days, or may even more. Pace and intensity of BP lowering is the same thing. It depends on the presence of certain conditions. Aortic dissection, eclampsia, pheochromocytoma crisis, intracerebral hemorrhage. These situations demand more aggressive approaches to limit ongoing injury. You see, on the other hand, ischemic stroke requires, more conservative management to avoid peri-infarction hypoperfusion and worse stroke outcomes. So consensus recommendations are based on very limited data and in some cases are not uniform across the guidelines. If you see different guidelines, they will say differently. Here I will provide some of the information recommendation from 2017 ACC American Heart Association guidelines, which is being endorsed by so many guidelines subsequently. This is the recommendation for intracerebral hemorrhage. This is the class of recommendation, and this is the level of evidence. This level of evidence, I'm not going into the details. You see recommendations for management of hypertension in patients with acute intracerebral hemorrhage. This red thing is doing harm. Immediate lowering of blood pressure less than 140 is harmful. And you see in adults with ICH present 220, it is reasonable to use continuous intravenous drug So continuous intravenous drug must be used. So this is the recommendation. You see management of hypertension with the same thing here. Lowering less than 140 is harmful, and IV drugs must be used. The evidence is class 2A. For ischemic stroke, I'm not going into the details. You will see the recommendation. The class of recommendation 1 in these two, and adults with acute ischemic stroke and elevated blood pressure who are eligible for treatment with intravenous tissue plasminogen activator. Nowadays, this intervention therapy for ischemic stroke is being prevailing even in our countries. So if tissue plasminogen is given in one patient, then the target is different if it is not given. And BP slowly lowered to less than 185 to 110 before thrombolytic therapy is initiated. And an acute ischemic stroke, BP should be less than 185 to 110 before administration. The same thing, but I'm not going into the details. Starting or restarting antihypertensive therapy during hospitalization in patients BP greater than atho who are neurologically stable is safe and reasonable to improve long-term BP control unless contraindicated. Ischemic stroke, it's harmful, no benefit. If in patients with BP less than atho who did not receive intravenous thrombolysis, requiring acute antihypertensive treatment, initiating or reinitiating treatment of hypertension within 48 hours to 70 hours in acute stroke is not effective to prevent death, or so 48 hours or 72 hours, you need not to reduce the blood pressure if the patient is not a candidate for thrombolytic therapy. So these guidelines are there, and we have to choose according to these guidelines. I'm not going into these. You see the blood pressure, I'm just going into a details algorithm. Blood pressure is more than the defined level. Then you have to look for target organ damage, brain damage, some features, retina, heart, large vessels, aortic dissection, kidney. And then if these are not present, then confirm persistent elevation in 30 minutes again. If the symptoms attributable to high blood pressure no jodi hoy tahale urgency, আর যদি yes হয় urgency, but you have to be very rapid. Oral agent, এখানে হলো long acting agents, এখানে oral agents with some rapid action. If these are present, then this is emergency. So these are the algorithm we have to follow. Now please, dear audience, come to the first case. This first case, very high rise of blood pressure, anxious chilo, tar ekটু blood vision chilo, only finger counting chilo, is very difficult situation. So sorry. So what is the diagnosis in this case? You see, in posterior parietal occipital region bilateral, there were hypointensification, hypoattenuation. So it was very acute, high rise of blood pressure. It was press. How will you evaluate and treat? The diagnosis is hypertensive emergency, and blood pressure should be reduced by 25% up to 25% within 1 hour, then gradually to some of the level. So these blindness and other things will be just reverse. That is why this is press. Case 2, there were no target organ disease. So, and patient was anxious. So this is hypertensive urgency. So you need not to be very prompt, very aggressive. just only giving assurance to him, oral medication, and he can be managed in ambulatory situations. So, Mr. Chairman, sir, in conclusion, I would like to say that acute severe hypertension is accompanied by acute target organ injury. The hypertensive emergency is associated with substantial morbidity and in-hospital mortality, requires immediate treatment, preferably, if possible, in the ICU setting with intravenous drugs. The acute severe hypertension without target organ damage is hypertensive urgency, and as in our second case, is not associated with adverse short-term outcomes and can be managed in the ambulatory settings. Non-adherence to previously prescribed antihypertensive medications is the most common factor leading to acute severe hypertension. Chronic hypertension shifts the cerebral blood flow autoregulation curve to the right. So you have to be very cautious in reducing blood pressure, which confers a predisposition to cerebral or other tissue hypoperfusion at relatively higher blood pressure levels. These principles guides the pace of blood pressure reduction in acute hypertension. This pace, how rapidly and to what level, is very important. And there is no cutoff value like 140 by 90. There is no cutoff value like 180 by 110. But you have to be very cautious during reduction of blood pressure, and you have to be kept in your mind the autoregulation of blood pressure, the autoregulation curve. Hypertensive emergencies are managed with intravenous medications guided by the type of target organ damage. It depends. And hypertensive urgencies should be managed with oral medications that I have already discussed. So, Mr. Chairman, sir, dear audience, thank you very much for your patience hearing. Thank you. Thank you, SCB Bangladesh chapter, for providing me this opportunity. And thank you again. Thank you all.
Sadly, we have come to the end of today's program. We have Thank you so much, sir, for your excellent, amazing presentation. Now it's time for the question and answer session. These are the questions that you asked in the comment section during the live session. Firstly, we apologize. Thank you so much, sir, for your excellent, amazing presentation. Now it's time for the question and answer session. These are the questions that you asked in the comment section during the live session. Firstly, we apologize. We will be able to answer all of them, but we will try to answer as much as possible. So, let me request Dr. Maglin to start the question and answer session. Dr. Maglin.
Thank you, sir, for your elaborate discussion on hypertensive emergencies, both hypertensive urgency and emergency. I think most of our questions have its answer. But now the question and answer session, we have lots of questions in our comment box, but due to time constraint, we may not able to present all the questions to our learned speaker. But I shall try to present a few of them. First, Mr. Munadi A. Islam asked about, sir, can please brief on PRES syndrome and its association with hypertension?
Thank you. PRES is a very rare cause of hypertensive emergencies. But there are other situations, other conditions that can precipitate PRES. The rapid elevation of blood pressure is one of the precipitating factors. The lupus is a precipitating factor. Sometimes eclampsia, preeclampsia can be a precipitating factor. What causes the involvement of the brain is very difficult to predict, because after 3 or 4 days, all the presentations gone from the CT finding from brain. It is postulated that there occurs some edema in the posterior circulation, especially the visual cortex, and that is why almost all patients complained of blindness, and after within 7 days, it is a reversible phenomena. That is, there are other conditions. I'm not going into the details, praise, but hypertension is one of the important precipitating factor for praise. That is why I just taken this as an example.
Thank you, sir. Our next question is how to manage hypertensive urgencies in stroke patient, both ischemic and hemorrhagic stroke. I think sir elaborated it. Sir, question.
I think I have discussed it. The situations are different. In common principle, I have told that blood pressure should be reduced by about 20 to 25% within an hour. But for stroke management, it may not be true because there are some limited randomized control trial, and basis on that RCTs, the guideline I have discussed, they have proposed not to reduce blood pressure very quickly in intracerebral hemorrhage, and that was not less than 140 is harmful even. So the blood pressure must be only 25% of the initial to be reduced by an hour. But in case of ischemic stroke, it is not true. Ischemic stroke in our setting, because in all our ischemic stroke patients, we are not prescribing any procedure like the thrombolytic therapy. In that situation, blood pressure should not be treated if it is very high within 48 to 72 hours. We should not reduce the blood pressure. And after that, we gradually reduce the blood pressure because of that autoregulatory mechanism. If the blood pressure is not at that level, then you have to follow the previous recommendation that you should reduce the blood pressure by 25%. If it is with the less than 180 by 110, then it should be reduced gradually over time. So in other situations, when the aortic dissection, when there is eclampsia, or when there is aortic dissection, you have to reduce very rapidly. But in ischemic stroke, you have to go very slowly, keeping in mind those guidelines. I think guidelines are available. You can go through those guidelines, then you will be finding all the details of the recommendation.
Thank you, sir, for your answer. Next question is how to start antihypertensive in newly diagnosed hypertensive patient who came to us with hypertensive urgency.
This situation may be like that hypertensive urgency, that is, there is no target organ damage. So the patient did not know about the presence of hypertension previously. Then you go slowly, like you have to take a very good history from the patient, from attendant, that is there any precipitating factor, is there any drugs those can cause acute elevation of blood pressure, or is there any stress factor. So after evaluating, you have to start antihypertensive drugs. So it is in the urgency level. So at least combination drugs should be added, long-acting drugs should be added. You have to, there is no scope of delaying in starting the drugs, because you start in a very lower drug regime and with a quicker follow-up. That is, you start 2 drugs combination, or you can use 1 drug depending on the various factors, whether the other evidences of target organ involvement. The patient did not know, but you find that the apex is shifted. You find that there is some changes in the ophthalmoscopic examination. So it indicates that the long-term presence of blood pressure in that individual. So it depends on this situation. If there is no target organ involvement, you start single drug. If there is long-term elevation of blood pressure evidence, then you start with 2 drugs. Usually, if the blood pressure is more than 160 by 100, then it is recommended by the guideline that you should start 2 drugs with a very minimum doses, then follow the patient. If it is very high level, then you follow the within 7 days, give a second follow-up. So this is the option. And choice of drug, the choice is either calcium channel blocker or ACE inhibitor, or both of them maybe. If it is not applicable or it's not reducing the blood pressure, then add another class of drug to that combination. So I think this is a very tricky situation. You have to be very cautious whether the patient has got long-term hypertension, any evidence, or there is no evidence of long-term target organ involvement in that individual. Thank you very much for your nice question.
Thank you, sir. Your answers will be beneficial for the clinicians as also as the examinee. Now, we shall move to the panelists today. We have 2 renowned professors and good clinicians among us as a panelists. First, we have Professor MD Zakir Hossain sir and Professor MD Uddin sir. Professor MD Zakir Hossain sir is the professor of medicine at TMSS Medical College, Bogura, and founder chairman of Hypertension and Research Center, Rangpur. I invite Professor Zakir Hossain sir for his valuable comment. Sir.
Thank you, Dr. Maglin.
Thank you,
for giving me the chance. Honorable Chairperson, Professor Tarikul, sir, my friend, distinguished speaker, keynote speaker of this session, Professor Dr. Mujibur Rahman, panelist Professor Zahir, and dear participants, Assalamu alaikum. I enjoy the session. Professor Mujibur Rahman nicely presented today's topic, that is hypertensive crisis, urgency and emergency, with evidence, with some evidence-based, with some papers. So nicely described, emerging presentation. I think all of us enjoyed nicely. Though hypertensive crisis, this terminology only found in ACC and AHA classification. No other classification, in fact, describe this term. But severe hypertension in the earlier time, or malignant hypertension, in fact, this is under the heading of hypertensive crisis. Now, this crisis, urgency and emergency, depending on target organ damage. Now, I am hearing patient having severe hypertension without target organ damage, but at the initial time, at the time of presentation, sometimes it is very difficult whether is there any damage of any target organ, whether present or not. Needs for history taking, clinical examination, and sometimes needs a lot of investigation to level it. On the other hand, if a patient having history of stroke in the earlier time, now getting antihypertensive treatment, and now and almost all the time pressure remains normal, suddenly developed very high blood pressure. In that case, it is very difficult whether this target organ damage, that is stroke, is acute or it is old. So very much difficult to label him as emergency or urgency. Sometimes it is very much difficult. Again, many of the patients having hypertensive nephropathy, there is proteinuria. And on treatment, his blood pressure remains stable. All on a sudden, due to some irregularities in treatment or some acute condition, there is high blood pressure, and routine examination, urine test reveals proteinuria. In that case, it is very much difficult to label this patient whether he has been suffering from urgency or emergency. So these are some situation, difficult situation to label the patient as hypertensive urgency and emergency. Professor Mujib said acute elevation of blood pressure and rapid rise of blood pressure and with evidence of acute end organ damage. So acute end organ damage or damage present or already happened earlier time, it is very difficult to differentiate at the chamber or within a short period of time. So needs previous documents. So our patient usually have sometimes have previous documents, many of the patient having no previous documents. So I think it is difficult situation. I especially thanks Professor Mujibur Rahman regarding evidence-based discussion, and especially thanks for cerebral autoregulation, clear discussion on cerebral autoregulation. It is very difficult, and আমি বিশেষ করে সেরিব্রাল অটোরেগুলেশন ঠিক ভালো বুঝতাম না, কিন্তু আজকের প্রেজেন্টেশনে আমি নিজেই খুব ভালো বুঝতে পারলাম। বিশেষ করে তার যে গ্রাফিক্যাল প্রেজেন্টেশনটা আমার খুব ভালো লেগেছে। আমি আবারও প্রফেসর মুজিবকে ধন্যবাদ জানাচ্ছি এই সুন্দর একটা প্রাণবন্ত প্রেজেন্টেশনের জন্য। ধন্যবাদ, এসিপিকে ধন্যবাদ।
Thank you, sir, for your valuable comments. Now we also have Professor MD Uddin sir among us. He is the head of the department and professor of medicine at Popular Medical College, Dhaka, and member of the executive committee, Bangladesh Society of Medicine. Now I would like to invite Professor MD Uddin sir for his valuable comments.
Thank you, Maglin, for your invitation. I would first like to thank Professor Mujibur Rahman for his brilliant presentation. Askar presentation maximum দিকটাই Professor Mujib cover করছে, যে what is emergency, what is urgency, and what are the precipitating factor, what is the underlying cause, and how to evaluate the patient and how to manage the patient. I think most of the side is covered by his presentation, and audience are can easily understand if his patiently hear his presentation. There is some common question and common problem in our clinical settings, particularly when a patient have hypertension, severe hypertension, but rapidly rise of hypertension with stroke. And Professor Mujib has nicely explained how to manage it. One thing is that when the pressure is 220 or by 120, or the patient has ischemic stroke, patient unless the pressure is more than 120 diastolic and 220 systolic, 200 or 220 systolic, this patient should not be given antihypertensive drugs, as because patient pressure will gradually decline within next few hours to days. Particularly within 3 days, commonly pressure may come down. But there is some exception commonly, that is when the patient have hypertension with ischemic stroke below pressure to 200 by 120, suppose it is 180 by 110, but the patient have ischemic heart disease or heart failure or the renal problem. In that case, we should give the antihypertensive drug. But in otherwise, if it is more than 220 or 100, 120 or 220, in that case, antihypertensive drug should be given, and it is an emergency. In that case, our target BP should be lower. In the first hour, it is not less than it is should not be not more than 20 to 25%. Another exception is the when but not in commonly practicing in our country, like the thrombolytic therapy. In few center in the patient may candidate for thrombolytic therapy. In that case, the blood pressure, unless you down the blood decline the blood pressure below 160 to 100, in that case, thrombolytic should not be given. In that case, the situation is different. In the hemorrhagic stroke, again, the pressure, the target pressure should be, if it is more than 180 and more than 110, in that case, the pressure should be rapidly falls, but not, it should be again, it should be declined by giving the intravenous drug, but not less than 20 to 25% in the first few hours. But again, our target should be the systolic pressure. Keep the systolic pressure more than 140 or 60, and diastolic pressure more than 100. Always, we should not, our target should not be the below diastolic pressure 110 in the even in hemorrhagic stroke, below 100 in the diastolic pressure. This is the very common question and common phenomena. When the patient is come to our ward with stroke and hypertension, this is very common situation. In that case, our doctors usually the pressure is 180 by suppose 110 with an ischemic stroke, but without having this situation, special situation, they commonly give the antibiotic drugs. In that case, we can wait. That is the common. That is the main message. You should not give the antibiotics. You should not give the drugs to fall the blood pressure rapidly. The other things is very nicely described. This there is some history, evolution, and history is very important. What is the cause of his sudden rise of blood pressure? The most common cause actually the irregularity of the medicine. আমরা কি করি, প্রেশার ওষুধ খেলে রোগীরা কি করে, প্রেশার নর্মাল হয়ে গেছে, ও আর ওষুধ খাওয়ার দরকার নেই। ইভেন কি ফার্মেসিতে গেলেও আপনার প্রেশার তো নর্মাল হয়ে গেছে, আপনার ওষুধ খাওয়ার দরকার নেই, ওষুধ বন্ধ করে দিল। এরাই হলো মূল কারণ, এরাই হলো এই হাইপারটেনসিভ ইমার্জেন্সি সিচুয়েশনটা এদেরই ডেভেলপ করে, আর্জেন্সি সিচুয়েশনটা এদেরই ডেভেলপ করে। এটা হলো ওয়ান অফ দ্য কমন কারণ। আরেকটা কমন কারণ হলো তারা অ্যান্টাগনিস্ট কিছু ড্রাগ খায়। আর একটা থার্ড কারণ হলো আন্ডারলাইং সাম সেকেন্ডারি কন্ডিশনটা হয়তো আগে ডিটেক্ট করা হয়নি, লাইক পেশেন্টের রেনোভাস্কুলার হাইপারটেনশন, ফিওকোমোসাইটোমা আর কিডনি ডিজিজ। এই ধরনের ডিজিজগুলো হয়তো আগে ইভালুট করা হয়নি, তাকে অ্যান্টিবায়োটিক ড্রাগ দেওয়া হয়েছে। এরাও কিন্তু হাইপারটেনসিভ ইমার্জেন্সি নিয়ে আমাদের কাছে প্রেজেন্ট করতে পারে। অন্যতম প্রধান কারণ হলো যে ইররেগুলার মেডিসিন, প্রেশার নর্মাল হয়ে গেছে, বাস ওষুধ খাওয়া লাগবে না, তারাই সবচেয়ে বেশি এই ধরনের কন্ডিশনে আসে। আর সেকেন্ড যেটা আমি বললাম যে আমরা সেকেন্ডারি কজগুলো হয়তো আগে ভালো করে ইভালুট করা হয়নি। এর মধ্যে ফিওকোমোসাইটোমা, রেনোভাস্কুলার হাইপারটেনশন, এই দুটা জিনিস কমন দেখা যায় যে হয়তো করা হয়নি, তারাই পরে দেখা যায় যে ইমার্জেন্সিগুলো নিয়ে আসে। সেই জন্য ইভালুশন ইজ ভেরি ইম্পর্টেন্ট বিফোর স্টার্টিং দি ট্রিটমেন্ট। With these few words, again I am giving thanks to the Professor Mujib for his excellent presentation, and also the ACB Bangladesh chapter for giving me the chance to as a panelist. Thank you all.
Thank you, sir. Now we have come to the final stage of our today's session. Now it's time to hear the talking of our chairperson, sir. We are honored to have Professor Qazi Tarikul sir among us as the chairperson, who is the former governor of ACP Bangladesh chapter and former president of Bangladesh Society of Medicine. I would request Professor Qazi Tarikul sir to make some few comments on today's health talk and to conclude the session. Sir.
Thank you very much. First of all, I beg pardon because I had two back-to-back sessions. First, I had one session from 9 where I presented COVID-19 vaccine an update. What happened, so a lot of questions are there, so I could not make my time in time, but I joined 10, 15 or 16. So I missed Professor Mujib's lecture possibly 10 to 12 minutes or 15 minutes. But the last portion, what I have listened, I thought that he put some clinical vanity, then for the learners as well as for the uh, other teachers as well as those who are participating. I think it was wonderful. And regarding Professor Mujib, what I will tell, because I have listened a lot of his lecture. He always made his lecture preparation in such a way that it is always attractive. And obviously, it is evidence based. And there is no doubt that today's session was excellent. And from 10:15 up till now, I'm with this lecture. I was listening. Even the press, he was when talking, I was remembering that one case we reported later in a journal that was referred from gynae and obs. It was a case of eclampsia. I think it is in 2016 or 17, 16, I think. Actually, when the patient was talking about blood pressure and headache, they thought that this is possibly either hemorrhage or something like that. The city actually guided us, and ultimately the patient left hospital with a very good condition, and no review CT did not show any lesion over the posterior reversal, what the press is talking about. This is interesting, and obviously there is the talk he has given. This is the usual thing we should do. Also, the two panelists, they are very famous professor in internal medicine. We get a lot of hypertensive urgency and emergency in, they got admitted, then the floor doctor become very, or the working doctor, those who are on duty become very puzzled what to do. You should go by evidence-based line, so that at least you should be very clear in your mind that you did not do any mistake or wrong. Patient may die, but it should not be because of your ignorance. That is the message Professor Mujib has given. মানুষ তো মরবে, এই এমার্জেন্সি আর্জেন্সি যাই নিয়ে আসুক, ক্রাইসিস হবে, কোমরবিড কন্ডিশন থাকতে পারে, যেটা প্রফেসর জহিরও বলছিলেন। কখন কমাতে হবে দ্রুত, কখন কমাতে হবে ধীরে ধীরে, কখন আমি অবজার্ভ করব আওয়ারলি, এই জিনিসগুলোই কিন্তু আজকের এই হাইপারটেনসিভ ক্রাইসিস বা এমার্জেন্সির মূল মেসেজ ছিল। and I think it has been given very nicely for the audience. আমরা হয়তো অনেকে বলি যে স্যার আপনি কি 210 110 পেলে চুপ করে বসে থাকবেন যদি তার একটা স্ট্রোক হয়? ইয়েস, বসে থাকবো না। উই উইল স্টার্ট ট্রিটমেন্ট উইথ প্রোটোকল। এটা যদি ওয়ার্ডে বড় করে একটু টাঙানো থাকে কোনো জায়গায় যে এরকম আসলে এবং তার সঙ্গে যদি স্ট্রোক হয় তাহলে কি করব, এমআই যদি নিয়ে আসে তাহলে কি করব, এগুলো সব এসিসি এইচ এদের গাইডলাইনে চমৎকার করে দেওয়া আছে। ইভেন ইয়ের জেএনসি অবশ্য এখন অত আর হাইলাইটে নাই, অন্তত আমরা যখন 2001-এ প্রথম জেএনসি 7 আসলো তখন আমরা ফলো করতাম কম্পেলিং ইন্ডিকেশন, ক্রাইসিস কিভাবে ম্যানেজমেন্ট। এখন তো আরো আপ টু ডেট হয়েছে। এখন আমি মনে করি our students are much mature postgraduate student and the working physician. I will not extend my talk because already it is late night, and I hope that SCP will arrange such session in future on different topics. Professor Mujibur Rahman, thank you very much. I know you are a brilliant doctor and your talk is always palatable. I must thank our two panelists, Professor Uddin and Professor Zakir, who is a pioneer of management of hypertension in his a region, rather in his emperorship in the northern part of Bangladesh, and also Dr. Maglin for anchoring very nicely, Dr. Prince Kawser for hosting the program, and here our audience, listeners, thank you very much, and hopefully we will see each other in another session. Thank you very much, and I conclude here. Thanks a lot.
Thank you, sir.
Sadly, we have come to the end of today's program. We have learned so many essential things about the management of hypertension from Sir today. Many thanks to the speaker, the chair, the panelists, last but not the least, the moderator for managing time for this program from their very busy schedule. I'd like to thank all the audience who were with us. If you joined late or couldn't see the whole program, there is no need to worry. You will find the whole program on the YouTube right after the live session finishes. Our next health talk on acute medicine will held on 11th of November. So, see you all in the next episode.